big problems. One, it's the #1 cause of hospital readmissions. It's causing about $100 billion of preventable hospitalizations. It's causing about 350 preventable deaths each day here in the United States. And my company believes that we can come together and make a big impact and potentially save 1 million lives this decade. So the problem is very simple. People who need medications stop taking the medications early. There's a lot of factors that go into this, and I don't want to go there today. I just want to show you one tool that we're releasing in the near future and give you a heads up on it. But medication adherence space is a huge business opportunity, and it seems like there's two things that really work well and are cost effective. One is the pharmacist spending more time with the patient, talking to the patient when they pick up their meds, and the other is electronic monitoring systems. So my company is working on building a medication adherence platform. So we have the mobile medical server, which essentially is a cloud platform, and we're tying predictive algorithms and analytics to that. We're tying into some health data over here. We're tying into third-party applications over here, which basically means that for Q2, Q3 of this year, we're going to be doing some hackathons in this group, and we're going to be creating some solutions very quickly. But I want to show you what we're doing in Dallas Nephrology in the next, starting May 1st. So we have, I've got a team of data scientists who've been working on the Canary predictive engine. And so in Dallas Nephrology, which is 72 nephrologists with 30,000 patients, May 1st, their doctors will have on the screen before they go in to see the patient. The canary will be there, and if it's red, it signifies that this patient is at a high risk for hospitalization in the next 30 days. The doctor can then press the canary and go to a screen that shows the factors that are affecting that patient's risk. And it's simply about raising awareness at this point. Now, from the doctor's standpoint, if I identify someone at risk, there's three things that I might do. I might intervene directly, I might refer out, or I might make a medication change. And most often it's medication change. And that's really where we think that the biggest impact can be made in healthcare is by improving people's medication experience, improving medication adherence. But I'll just show you a quick video about how the canary works, and then open it up for questions.
Those patients listed in the text box are the ones that we predict are likely to need a hospital stay in the next 30 days. These are the risky patients.
Actually, it's probably easier for me to say. So what we're doing is looking at huge data sets of claims data, and we're predicting the risky patients based on those claims data. Now, because on day 0, we make a prediction, on day 30, we can test whether the prediction was true or not. What we have here is all the ones in bold are the ones we accurately predicted. Now, we have a sensitivity down here where we can change the sensitivity to how many patients we want to bring into this. So if we move the sensitivity up to 1, the engine predicts that all patients are risky patients. If we move it down to 1/3, it predicts that a smaller portion of them. So we're getting very good results right now with it, and we'll be implementing in Dallas Nephrology. And really what I'm looking for is we're trying to get to more ACOs. Right, so accountable care organizations right now, hospitals, right now they have a huge incentive to try to find out which are the risky patients and provide those patients with the solution before they come back to the hospital. Then the other side is working with plans, insurance plans, being able to, again, reduce their costs through this. So if anybody has contacts in health plans, ACOs, or the new ECOs, or ESCOs for end-stage renal disease, Fresenius and DaVita, that's what I would be looking for and seeing if we can find them today. Any questions about the Canary predictive engine?
Where do you get the clinical and the pharmaceutical data?
So this engine right now is built on claims data. When we integrate with Dallas Nephrology and their 30,000 patients via the Allscripts electronic healthcare record, we'll be also integrating with clinical data. And so our hypothesis is claims data and the clinical data will increase our predictive strength. The other piece of this is since we're focused on medication adherence, we're tying in with several third-party pill reminder applications, which now brings in a new data set of patients medication administration record. And again, we hypothesized that the combination of clinical data, claims data, and medication adherence data will give us a stronger predictive strength. So some of the data we're borrowing from Allscripts. Some of the data we're integrating with third-party applications that are already collecting the data but don't aggregate it into a central place.
Why did you choose nephrology as a starting point in terms of specialty?
Yeah, so the reason we chose nephrology is because nephrology is a special carve-out in Medicare, where you've got younger patients who are Medicare recipients. So the average nephrology patient is somewhere between 45 and 65. So these are young patients, therefore probably more likely to be smartphone users. But they also have medication therapy management with the pharmacist covered as part of their Part B Medicare benefits. So because of that, and because we've got access to the second largest group of nephrologists, that's our pilot site. Our strategy is to refine the algorithm for specialties of internal med. Although it works for all patients, we're trying to improve it for specialties of internal med. Anything else?
How do you make money?
Yes, in the back.
So the gist of your technology is the prediction of which patients are likely to be less adherent than others, but then you're relying on other solutions to actually improve the adherence. Is that the gist of it?
No, the Canary predictive engine is an easy way to identify high-risk patients. Now that you've identified a high-risk patient, what can you do? And with medication adherence, there's no single-size-fits-all solution. So the problem in the medication adherence space is there's a lot of great successful pilots out there and a lot of one-off applications out there, but nothing's bringing this together and bringing the data back, and it's just a kind of a bit of a messy space. So for the third-party applications, we provide the back end that helps them to, one, grab new customers when you're at the pharmacy, but also that back end to close the loop back to the pharmacist or back to the prescriber. Does that make sense? Thank you very much, everyone.
Okay. Without further ado, I'll ask the presenter.